us, and I'm really excited about our webinar this evening. I'd like to thank everyone in advance for joining us on our Tuesday study group. And today we have Dr. Mayoor Patel. Dr. Patel received his dental degree from the University of Tennessee, and he also completed a one-year residency in advanced education in general dentistry. He's got his master's in science from Tufts and actually was a clinical instructor at the Craniofacial Pain Center at Tufts. Additionally, Dr. Patel has taken over 1,400 hours of postgraduate education course in the area of sleep medicine, craniofacial pain, sleep disorders, and orthodontics. And since 2003, Dr. Patel has limited his practice to the treatment of TMJ disorders, headaches, facial pain, sleep apnea, and snoring. So I'd love to welcome my dear friend and colleague, Dr. Mayoor Patel. Hello, Dr. Patel.
Hey, Rose. Thank you very much for that kind introduction, as well as Ms. Courtney Snow for helping me get all this up and running. I appreciate everything that Dental Practice Nierman does for our office. I'm very pleased to have a good discussion today about what the title of the slide was, the dentistry's role in screening for TMD and obstructive sleep apnea. But moving forward, the talk will be more geared towards why we need to get involved with both those two disciplines and try and go through some of the literature and case histories of why we as dentists should play an active role in treating such patients, better yet, also screening for them. Courtney, do you have control to advance?
I do.
If you look at thank you. If you look at the ADA, there's some statements as far as what dentist roles are as far as oral health is concerned, and there's a bunch of different subcategories that you can click on to learn more about it. But if we move over to the next slide, what you'll find is there's a summary there that suggests that we should be in a role to promote oral health and disease prevention. And the way I look at the word disease prevention, even though it's focal towards the oral cavity, but there's a lot of things in the oral cavity that can point us in the right direction to prevent diseases elsewhere in the body. And you'll get a better grip of what I'm trying to say here as this presentation moves along. On that same statement, there is a discussion that is more than just teeth and gums. If you look at that for a minute, and you look at the statement there, they say that dentist areas of care include not only the patient's teeth and gums, but also the muscles of the head, neck, jaw, the tongue, salivary glands, but more importantly, the nervous system of the head. And the nervous system is where we see a lot of correlation with the nerves that go to the face, the nerves that go to the jaw, and it's cross-correlation with neck issues or even headache issues that we'll talk about here shortly. So what it boils down to is we should be in a position to look for abnormalities. We may not be in a position always to be able to address these abnormalities, but at least by identifying them and spotting them, we can find early signs or early warning signs and refer these patients to the appropriate healthcare providers to either be treated, us ourselves treat, or get a diagnosis made so that we can proceed further with such situations. There was a paper done and published in JADA talking about the role of dentistry purely from the standpoint of screening. And what they were looking at is screening coronary heart diseases. And what they found is that we were in a unique position of not only identifying these patients, but more importantly, preventing cardiovascular diseases from forming purely from the merit that more patients see dentists than they actually do see their own healthcare provider or medical doctor for that matter. That being said, there was another paper published in Public Health, and the interesting about this paper was they found that if dentistry took an active role in screening for diabetes, hypertension, and high cholesterol, you could save anywhere from $42.4 million to $102 million in healthcare costs purely on the merit of screening. So once again, we are positioned in such a way that we are able to not only identify but screen, counsel, as well as refer, and try and take the burden of chronic healthcare off our patients' backs. Now, like anything, sometimes you just get lucky. As I was putting this presentation together, a week ago I get this from AGD Impact, the March 2014. And it's a topic or a discussion about dentistry and medicine. And if you look into this little article that was written, there was a cartoon that showed that 20 million Americans annually visit a dental practice, but not necessarily a medical practice. And that's 20 million people that we may have direct contact with not only identifying, but more importantly, screening for other issues. But as they interviewed one of the doctors in this, there was a statement that he made that, but I don't just want to screen, I want to provide care. And he goes on saying, oral facial pain treatment and dental sleep medicine are two expanded areas where as a dentist I can really render useful and successful therapeutic service. And many of us that are in this field for that reason have found a lot of satisfaction in not only treating these patients, but also identifying them and getting them to the right place to get these diagnoses made. So what do we need to do? And what he basically comes down to is we need to take an active role in participating, but better yet, screening these patients. And one important reason for it is if you look at physicians' office visits, and you look at the literature and what it suggests, is when you have a patient in a medical practice, the amount of contact time they have with the physician varies. And on this survey, as my physician, when I go to see him, I'm in the first little graph, less than 9 minutes. I'm lucky even if I get 9 minutes, which is roughly 5% of the physician survey. But you can see the most you're going to get at the 20% marker of contact with your primary care physician is roughly anywhere from 13 to 15 minutes. Now, what the survey does not identify is some of this also involves them, you're being taken in to get your vitals done, not just direct patient care, physician to patient, but also where the auxiliary spend some time getting you prepped for the physician to walk in. So you can see the amount of contact time in our medical calling practices due to whether it's reimbursement or the practice philosophy they may have or the volumes of patients they may see. They don't take an active role, can't always take an active role in screening. So the next slide shows an interesting cluster back in 1979 and 1994 when they looked at the number one diagnosis in a primary care setting. And where they found that hypertension back then and presently is the number one reason why patients seek care at the primary care medical practice. Well, if you look at sleep apnea, one of the things about sleep apnea is untreated sleep apnea does contribute to hypertension. So could it be that a lot of these patients, purely by the merit of not identifying some of the root causes, are being seen in their primary care settings just to manage such symptoms? Now, if you look at statistics, and I'm going to basically muffle the statistics up with not just temporomandibular joint disorders, but we'll throw in also other components that you might see in your family practice. The prevalence of temporomandibular joint and muscle disorders ranges anywhere from 5 to 12%, depending on whose work you look at. And if you look at the prevalence of periodontal disease, it's roughly 8.52%. Now, that being said, many of you have finished their hard day of work today, and you may have found a handful of patients that had periodontal disease. It didn't take much to identify those patients because you were looking for it. Well, if you look at the distribution of the prevalence of temporomandibular disorders, it's not that far off. So for every periodontal disease patient you found today, one of those cluster of patients should have had some form of temporomandibular joint or muscle disorder. But the reason we may never always find it is we never ask the right questions or have systems in place to flag these patients. Looking further down, if you look at the prevalence of sleep disordered breathing, SDB, 24% of men, 9% of women, much greater than your periodontal population, much greater than the temporomandibular joint population. So once again, today, you should have found or identified a handful of patients that may have had a sleep disorder breathing issue and they didn't know. But if we jump down to the last bullet point, if you just look at the prevalence of headaches, 78% of your patient population have some form of degree of tension type headache and 16% migraine. Those numbers much greater than what you'd find when you're looking at periodontal disease. So we typically do a lousy job screening or identifying those patients. And these are services that you could provide in your practice, both from a sleep disorder breathing perspective, as well as temporomandibular joint or chronic headache. If we go further down to the next statistics, you'll see that, all right, between the ages of 20 and 64, 60% of adults basically have seen a dentist. And if you look at some of the literature, 55.5% have seen in primary care. But the 55.5%, the most commonly diagnosed condition, once again, was hypertension. And a lot of times, hypertension can be curbed if we can identify, in some instances, the etiology, and one of which will be sleep apnea that I will demonstrate here shortly. So even though the distribution in this slide seems about equal from a dentist standpoint to a physician standpoint, it's still not identifying these patients appropriately. Now, if you look at the press, and you look at what's out there in the literature, and if you get on the internet, you'll find that there's a lot of work or press releases on diabetes. There's a lot of correlation with sleep apnea and diabetes, sleep apnea and cancer, sleep apnea and stroke, and things of this sort. There's a lot of information out there. There's a lot of patient awareness within reason that's actually taking place. The only problem is identifying these patients right places to get the diagnosis done. So the dentist's role, I mean, if you really get down to the nuts and bolts, patients' oral health may be affected by his or her oral health, and we've known this. We've known this for a long period of time. But the role of the dentist in managing medical conditions is expanding rapidly, and there's a lot more push, and there's a lot more work to try and get dentists to be a little bit more proactive with some of these medical conditions that we may see, and be in a position to actually treat them. And we've done a fantastic job when we look at bullet point number 2. There was a trend in the literature back in the days connecting cardiovascular diseases and periodontal disease, and I think in the early years it was speculation, and as time has progressed, we do have a strong discussion about gum disease and its effect on cardiovascular disease, and we spend that time. But interestingly enough, cardiovascular diseases can also be impacted by sleep apnea. So why are we not taking an aggressive role in identifying and or educating our patients of the effect of sleep in cardiovascular diseases? Now, this little graphic here is a graphic that we use in our marketing piece here in our office. We basically have our logo, but we basically point out to many healthcare professionals that in your practice you may have patients that have these multitude of symptoms. For example, upper left. You might see these patients in a neurology practice or a chiropractic office where these patients are chronically complaining of forehead, temple, migraine, and sinus type pain. In an ear practice, you might have a lot of patients complaining of ear pain, ringing in the ears, dizziness, vertigo, fullness. When you go to the eyes in an ophthalmologist practice, in the dental practice, you've got the teeth correlations, and you've got some of the jaw components associated with it. And of course, the neck. And in the neck, you've got the chiropractor, the physical therapist, the physiatrist, or chronic pain management. But what all these things are trying to identify is that there's probably a good chance that this individual here may be suffering from a temporomandibular joint issue that has not yet been identified effectively or treated for that matter. This paper in Cephalgia in 2008 basically looked at headaches and temporomandibular disorders related. And this is a debate that comes up over and over again. And there's some signs, some great papers to actually point you in the right direction and suggest that there is some form of a correlation. The way I read this paper is it says that the prevalence of TMD in the headache population is roughly 76.1%. So just to make it simple, let's just say 50%. So the converse would be true. A headache sufferer, half of them probably also have a TMD component. All right? If we go on further, the study looked at that the chronic, ongoing TMD patients have headaches that were not being resolved. And they were suggesting that the importance of examining the masturbatory system in headache sufferers is extremely important because of this connection and correlation. And this next study that you're looking at right now, the connection of temporomandibular disorders and sleep bruxism, this has been for debate. Does sleep bruxism contribute to temporomandibulitis and so forth? And what they basically found is there's an association, roughly 1.6 to 5 times more likely that a bruxer would have some degree of temporomandibular joint disorder. Well, that being said, if that's so true, we get so into providing night guards and things of that sort to control bruxism. But what about addressing some of the chief complaints, such as the chronic head pain, neck pain, things of that sort, that's a result of the temporomandibular disorder that they may be having? It also suggested that in that same patient population, there was an increased risk for episodic migraine and episodic tension-type headaches. So looking for these patients and working backwards, finding these headache sufferers or these migraine sufferers, and looking for temporomandibular disorders should be an integral role for any dental practice. This next slide is a piece that we have for our marketing purposes. Every letter that I send to a physician has an abstract of articles published pertaining to migraine and temporomandibular disorders, or headache and temporomandibular disorders, and we slip this in with every letter that we send. And the letters I'm referring to are the letters that we draft up from Dental Writer. And this is kind of free PR, but what we get is a lot of inquiries. And interestingly enough, from a physician's perspective, a lot of referrals, purely because you're providing them the literature, the science, what's out there. And if you look at some of the references, it's from the Headache Journal, or the Oral Facial Patient Journal, or the Cephalgia Journal. Not much literature that I've suggested in this abstract is from the dental, purely showing that this is stuff in their industry, not ours. So if we go to TMD screening, and we look at the ADA's guidelines, they suggest that a screening history and examination should be done for TMD disorders as part of your dental record keeping. There was an opinion on this that was then republished in 1990 saying that it's an essential part, which is your next slide that you'll see here shortly. It's the essential part of your routine dental examination, and some form of documentation should be pertinent as far as your evaluation for patients. So that being said, we should have some degree of record keeping. And if you belong to the Academy of General Dentistry, their position on this is just learn how to screen. once again, all points in the direction that some form of screening should take place on a daily basis. So the population studies, what is out there? And if you look at it, roughly 75% of the population has at least one sign. That does not always mean that you need to treat it, but more importantly, you should document it and then track it as the patient comes into the practice. The next bullet point is 34% have at least one symptom, and this is the patient population that you might be chasing after. This is the population that may need active therapy. And if you take a look at the ones that are symptomatic and you break that down even further, 60% have some degree of joint sound, probably indicative of an internal derangement. Then you've got the muscle tenderness if you were to palpate, limited opening if you were to check range of motion. If you were to palpate the lateral borders or the sides of the jaw joint, you'll find some capsular pain, and of course headache and facial pain. What's interesting, even though these numbers are numbers in the literature, in our practice, the majority of our patients, greater than 50%, are headache and facial pain symptoms, and the others are scattered between the rest. So what are some of the signs of temperamental disorders? And I must apologize if this is nothing new to many of these on this phone call, but I feel like I'm building a case, and hopefully by the end of this, you'll see where I'm going with this. So we got clicking on opening or closing. Sometimes we just consider it a benign issue. We document it, don't think much about it, but we should ask questions associated with it. Very rare would you have a patient coming and say, I had a dislocated jaw and I had to go to the emergency room. But it does happen. Jaw locking is pretty common. You'll have patients suggesting that they had a clicking popping joint at some point, and then it quietened down. But when it quietened down, they were not able to open as wide. If clicking popping did take place, jaw went quiet, and there's some progression of disease process, you may find that you start getting a crepitus sound on opening or closing. Crepitus is purely suggestive of possibly arthritic changes in the joint. We also have the bruxes that we need to be very, very aware of. Then we have those that have daytime clenching habits or parafunctional habits. Those of us that take panoramics may have an opportunity to look at the condyles, and if enough time has lapsed, you'll see evidence of some changes, typically beaking of the condyle ahead. Once again, I've only had one in my 8 years of a person walking with a locked open situation. I believe a lot of these patients probably land up in the ER. But the point is this is one of the signs associated with temperamental disorders, which could be directly correlated with ligament laxity and hyperextension. Limited range of motion, once again, very common associated with jaw locking. And a key thing that we always do see at times, but really don't take much attention to, is looking at patients from the front and just having them open and close, and get a sense of where, if we were to put a dot on the upper 8 and 9 on the lip, and a dot between 24 and 25 on the lower lip, do those two dots follow a straight line? Do they go off to one side and then come back to midline, or do they just go off to one side? And these are important things that we should note in our record keeping, but suggestive of us looking for other reasons why this is happening. If we continue and we start looking at signs and symptoms of what's abbreviated here as sleep disorder breathing, you'll find that most patients with sleep disorder breathing will complain of snoring, fatigue of some sort, where they describe it as excessive daytime sleepiness, not being refreshed upon waking. This is where they have to levitate towards some form of stimulants, whether it be Red Bull in the morning, coffee, and things of that sort, or a bed partner noticing them choking or gasping for air, or they themselves waking up from a gasping episode. Fatigue as the day continues, especially mid-afternoon, lethargy, depression, and morning headaches. And why this is important is, funny enough, but most temperamental disorder patients will also wake up in the morning with morning headaches. So the dilemma that you're at is this morning headache due to either parafunction reasons, or is this morning headache directly due to sleep disorder breathing, or the two correlated? And we don't have time to look at the literature as far as that's concerned, but to take my word for it, there's a lot of crossover between temperamental disorders and sleep disorder breathing. If you come to one of the seminars in May, I'll spend some time educating you on that. But there's some literature here that we need to really look at, and this is the knowledge of our primary care physicians. In this paper, they basically sampled. They found that a lot of the physicians were underinformed about the clinical features. And we talk about clinical features, we talk about maybe retrographic mandible, vaulted palates, physical features that you need to look for that may be suggestive of a sleep disorder breathing. The stereotype, overweight, big neck, things of that sort. But what about the subtleties that may explain why skinny 24-year-old female, BMI of about 18, 19, 20, has sleep apnea? Because if you look to the mouth, maybe they had a vaulted palate, 4 bicuspid extractions were taking place, they had retrographic mandible, a large tongue. So we need to look at clinical features. And what they basically suggested that they were very poor in identifying clinical features and not in a position to at least identify patients with sleep apnea. The other paper looked at it from a knowledge standpoint, and what they found is most PCPs rated their own knowledge of sleep disorders as fair or poor. There's a book published that talks about sleep and sleep specialties and things of that sort, and in there was a statement made finding an expert, and it suggested that most medical schools on average spend about 20 minutes teaching the subject matter. Now, I must say, this is an old reference. I am sure as time has evolved, the minutes have increased, but still, we talk about minutes. We're not talking about days of education here. But is dentistry any better? And the next slide will show that I don't think we do a better job. This being as recent as 2010, when the survey was done by Simmons and Group, and they found that 2.65 hours was spent with dental students educating them on sleep disorder breathing. So dentistry does not do a good job. Medicine does not do a good job. I think it boils down to us just looking for that information and doing something with it. Yet in 2002, in Sleep and Breathing, there's a nice article describing that there's a huge underdiagnosis of sleep apnea syndrome in the U.S. communities. And there's a lot of alarming facts within this paper. So there again, we need to, as dentists, play an active role in either bringing us up to speed or getting involved in this area of expertise. Young and his group published this paper looking at the estimated amount of patients that were probably not being clinically diagnosed, and they found that 92% of women, 82% of men with moderate to severe sleep apnea syndrome have not been clinically diagnosed. And that's a large number. And that being said, a lot of these patients are probably coming to a dental practice. But we need to take that active role. So what can we do? And what it basically boils down to is we need to screen every one of our patients, because you really don't know which one of your patients probably has this disorder. And this could be either temporomandibular disorders or sleep breathing disorder. It's been reported that only approximately 10% of patients with clinically significant sleep apnea syndrome have been recognized. So where's the other 90? And we need to do a better job tomorrow morning and look for the other 90. So if we change gears a tad and we look at dental science, and what are some of the things that could just stand right out there and give you an idea of maybe asking questions? One of the biggest ones is the vaulted palate. Development of the maxilla or underdevelopment of the maxilla can play a significant role with contributions to sleep apnea from the standpoint of the nasal passages being very restrictive. But then you got simple things, large tongue, warm enamel, these abfractions lesions that you might see on the like class 5 lesions, a mandibular thorax, a retrognathic mandible. We've got all the other components, scalloping of the tongue, which we do see day in and day out, but really don't give it much thought. Even if there was a history of TMD disorders or bruxism, once again, an important point here, warning headaches. Pain in the temples and nostrils as a result of probably parafunctional activities. But when I come back to this large tongue, there are many times in your clinical practice you'll find yourself fighting the tongue just to get to a tooth on the opposite end. If you're fighting the tongue when the person's awake, you just need to imagine the behavior of the tongue when the person's asleep. And that itself is a good talking point. I'm not going to spend too much time on this next slide, but what I do want to give you is a quick synopsis that, look, the act of being obese and the act of not breathing, which are the two elements on top, does create a cascade of reactions, all the way from oxidative stress to inflammation to what we call a sympathetic overload, which is contributing to hypertension, leading to all these chain reactions, which ultimately comes down to increasing your risk of cardiovascular diseases. Now, saying that, there are some papers that show the correlation between periodontitis and obstructive sleep apnea. And these are early studies, and I'm not going to draw a significant conclusion, but these studies remind me of the 90s when we were talking about periodontal disease and cardiovascular diseases, and in the early stages, we weren't sure where this was going to go. But now it's pretty much mainstream within reason. And I believe these next two papers are pointing in the right direction. This was looking at the fact that most apneics mouth breathe, and we know mouth breathing can affect periodontal health. The next paper basically looked at the stop scale, and we'll talk about what the stop scoring scale is. And they found a high correlation of the questions on the stop scale and those that were moderate to severe periodontal disease. So the fact here is there's some speculation that there might be some crossover, but we also know that periodontal disease is an inflammatory disease, and we know also the fact that sleep apnea, the act of not sleeping appropriately, does increase a lot of the inflammatory markers. So who knows where this is going to go in the future. So to look at screening, and I'll talk about that stop and the stop bang questionnaire in a brief moment, but there's ways to screen. And what we used to do in our early days when we were doing general dentistry is every patient that came in for a hygiene appointment has an Epworth sleepiness scale, and our hygienist would take a neck circumference and provide them with a BMI chart. Just ask them to tell us what their BMI was. We didn't want their height, we don't want their weight, because they were going to lie. We said, just tell us what your BMI is, and we'll just leave it at that. But the upper sleepiness scale, and I'm sure many of you know what it is. If you don't, just to kind of recoup and get everybody up to speed, it's a set of 8 questions. And it's 8 questions based on situations that you might be in, which is the next slide. It's the sitting and reading, the watching television, sitting actively in a public place, if you're a passenger in a car, lying down to rest in the afternoon, sitting and talking to someone, sitting quietly after lunch without alcohol, big point here, in a car while stopped at a few minutes at a traffic light. And you would rate the situation of you dozing off from 0, would never doze off, to 3, a high chance of dozing off. And what you're trying to get is a numerical representation of how fatigued or tired this individual is. It doesn't say anything more than just that. If they score greater than 9, it would be a wise thing to have a discussion about possibly sleeping, fatigue, things of that sort, and then referring them to get a diagnosis made. But another quick questionnaire or approach could be just asking questions. And we used to do this in our early days as well. And each one of those letters to stop means something. Yes, do you snore? Yes or no? Is it loud? Are you tired? Does anybody observe that you stop reading at night, especially those that were married or had bed partners? And if they had a history of hypertension. If they said yes to 2 out of the 4, there's a good chance that they probably had some form of a sleep reading disorder. But there's a component where you could ask the first 4 questions, which is on the South scale, and the second part called a bang. And the bang is basically B, is your BMI greater than 28? A, are you over the age of 50? N, if your neck circumference was greater than 17 inches for men and 16 for female. And G, gender, are you a male? And once again, if they said yes to 2 of these or greater, as well as 2 from the South scale, there was a good chance that they were probably moderate to severe apnea. So just the act of asking these questions could be suggestive of them having some issue or some condition. We had BMI charts in every hygiene room. We would just give it to them while we were getting the x-rays ready, things of that sort, and ask them, hey, what's your BMI? And we let them figure it out themselves. But the point is we know BMI or obesity does play a big risk factor for sleep disorder breathing. And you may not know this, or you may know this, but the review of medical history, we always ask this question, why do we ask all these questions? What's the reason behind it? And if you really played the detective role and looked at every one of these entities, each one has some representation of potentially having sleep disorder breathing. For example, if they said yes to headache, or they said yes to cardiovascular diseases, especially hypertension if they're taking more than 1 medication for hypertension, if they've had a history of diabetes, asthma, allergy, and depression. And if you go further down to this next slide, it's a synopsis of what's the probability of someone that has what they call drug-resistant hypertension having apnea. And studies have shown that in this scenario, more than 2 medications for hypertension, there's a good 82% chance that you have apnea. Obesity, 77. If you've had a history of congestive heart failure, 76% chance. So if you just look at those top 3 right there you've probably identified a whole bunch of patients that have had these conditions, but really have not looked at their sleep or their sleep pattern, or in this case, their sleep apnea, and treating it. Would you reduce these risks? And in some instances, the hypertensive, get them to come off some of the medications. But if you go further down this list, you've got diabetes, you've got coronary artery disease, and things of that sort. So the mere fact of them saying yes to some of these health questionnaires should raise your red flag up and say, all right, I need to ask a few more questions and get a little bit more information from them. So here's Bill, your patient that you can see tomorrow morning. If we just look at Bill's history here for a brief moment, his BMI is roughly 25.4. So no way is Bill obese. Age 53, so there's maybe the age component working against him. But if you look at his history, it's described that he has hypertension, high cholesterol. He's also had coronary artery disease in the past with a heart attack, and he has cardiac stents in place. His chief complaint in the practice was his snoring. Someone has witnessed that he has pauses in his breath, and he definitely scores high on the upward sleepiness scale, suggestive of excessive daytime sleepiness. As you probably see many of your patients taking aspirin as a prophylactic, taking Lipitor to try and prevent another cardiovascular incident from taking place, and taking Plavix. So this could be Bill tomorrow morning in your practice, and when you see that, you want to ask a few more questions. If we look at the risk of sleep disorder breathing, and I'll start at the 12 o'clock as far as the pictures are on this next slide that's coming up. When we look at the top slide on the top, and I'll work my way around in a clockwise fashion, we talk about retrognathic mandible. Just the act of having retrognathic mandible decreases the risk of sleep disorder breathing. Bicuspid extractions, which is the next phase. The fact that making the arches smaller to accommodate the teeth, but yet not proportionally reducing the volume of tongue, the tongue is going to have to do something as we age and lose muscle tone. The third picture being a vaulted palate. The fourth being bruxism or parafunctional activity. If you look at the 6 o'clock picture, tonsils. Just once again, meatballs in your airway, taking out real estate for air to passage. How else is this person going to breathe when they fall asleep and the tongue drops back? You've got the lateral tongue scalloping. This is things that we see every day, and we always have an excuse of why we see, but we really don't understand what it is. We've got mandibulatory, and then, of course, cervical abfraction. And this is where we get frustrated. We do restorations, and they keep on popping off. Well, they probably keep on popping off because the person's clenching. But it could be possible the person's clenching because he's not breathing well. So, ask questions. So tongue level, in your chair, just having them open and looking at the back of their throat, you're going to get a rough idea where the tongue is. If the tongue, the top of the tongue is underneath the occlusal plane, probably low likelihood that they have any issues associated with breathing. If the tongue base is at the soft palate, and you see a portion of the uvula and a little bit of the oropharynx, we got a tongue level that's a medium, probably a fair chance they may have some degree of sleep disorder breathing. In the last case, you just can't see the oropharynx. Probably a good likelihood that they have some airway issues. Another one that's a little bit more scientific might be the Malapati classification. I wouldn't completely hang my hat on it, but I do want to say 2 points about it. It's a good way to kind of get an idea of what the likelihood that the individual has of sleep disorder breathing issue. Class 1 is a scenario when they stick their tongue out. If you can see the entire oropharynx, we grade as a class 1. Class 2 is when the base of the tongue is at the uvula. Class 3 is when it's at the soft palate, and 4 is when it's at the hard palate. Now we do know, through some studies that have been published, class 3 and class 4 increases the likelihood of having sleep apnea by 5-fold for a class 3 and roughly 7-fold for a class 4. But I don't want you to rule out the fact that patients that have class 1, class 2 may not have a sleep issue. Likelihood might be low, but still worth investigating. This next slide is a short video of how you could probably incorporate all these steps in roughly 48 seconds, maybe a minute and a half when you're doing a hygiene exam. So it's just going to go through the process involved. Screening for joint sounds, jaw motion, by looking at palpation of the joint, looking at the midline, looking to see that the jaw is moving in a straight up and down pattern. You're measuring protrusion to get an idea of range of motion. If you use a 15-millimeter probe for your perineal issues, you can also measure lateral movement. Tongue levels, just take a quick look back there, and you're always going to do an oral cancer screening where you're going to have the tongue stuck out. Just before grabbing with the gauze, just take a look at the back and get an idea of the Malapati classification. And then look for tonsils. Do induce a slight gag so that the soft palate elevates, so you can look for the lingular tonsils in some cases. So the whole process here is roughly about 48 seconds. I mean, if you add another minute, it's not going to be about 2 minutes, and you'll get everything completed. So remember, Bill, this is his clinical presentation, and what you see here is a deep bite. All right, you don't even see much of his lower teeth. He also had some lower molars extracted bilaterally. I believe it's lower first molars. But this might just be a classical scenario of a patient in your chair, not overweight by any means, looks pretty skinny. Yes, when you look at his bite, deep bite, maybe a little bit of a retrographic component. It would be worth looking into. All right, so let's move along. We do know that bruxers brux more on their back. Well, the funny thing is apneics, most apneics have more apneic events on their back. So the question might be, could there be a correlation with the fact that not breathing and grinding may have a co-relationship? And the answer to that in a short way is yes. But if you look at some other papers, it's been shown that 1 in 4 patients that suffer from obstructive sleep apnea grind their teeth, which means every grinder that we have in a chair, we need to increase the likelihood of they possibly having a sleep disorder breathing or an obstructive sleep apnea event that should get diagnosed before we decide to stick them with mouth guards. That being said, there was a paper done and published showing that if you manipulate the airway by putting a night guard, it may affect respiratory events. It may affect respiration. In other words, if a person already has an apneic episode but never been identified, or is a snorer, and you stick them with a mouth guard to help them for teeth grinding, you could actually make the condition worse. And the next slide describes this pretty well. If you look at the top left slide, you look at AHI, the number of times the individual stops breathing, the apnea-hypopnea index. And what you'll find is, in some instances, it actually worsens the AHI. Baseline being without a mouth guard, the second one on the right split with a night guard. But what you also see in the lower right graph is is the fact that it increased snoring. So the mere fact of putting a mouth guard to help with grinding increased snoring, which you may want to ask the question, could it have affected the airway by any means? And the answer to that is yes. And I think like a lot of us, the only way we're going to learn is we got to make a mistake. And my mistake was with Scott. This next slide that you'll see here in a short second. Scott comes into the practice complaining of parafunctional events. Classic TMD case. Facial pain, no other components we could pick up on. He knew he ground his teeth. So with Scott, like anybody else, we want to protect his dentition, so we made him a night guard. Well, after a day or two of wearing the night guard, Scott calls us and says, well, I wake up every morning and the night guard's not in my mouth. And this was kind of puzzling at first, because we knew that in the office it took him a while to put the device in because of retention. It took him a while to get the device out. But what threw me off is the fact that it's not in his mouth when he wakes up. So we brought Scott back in the office and we said, Scott, I'm just going to look at your airway without wearing your oral appliance. Turned out he had a respiratory disturbance index of 11.4 with the oral appliance. And without the oral appliance, his apnea or respiratory disturbance index was 8.7. So I took a kid that really had a breathing issue that I did not identify, stuck him with a mouth guard, and made him much worse than he was at baseline, which totally explains why he was probably taking out the night guard purely from a reflex of not breathing at night. So this was my learning curve, and Scott really opened my eyes that there's a lot more to it than just putting plastic in someone's mouth. But that being said, if we circle back to Bill, and Bill was sent up to get a sleep study done. Well, it turned out Bill had an apnea-hypopnea index of 32.9, which automatically puts him on the severe range. But interestingly enough, on his back, he was 61.5, almost double. And you wouldn't think that looking at Bill's bill. But you also find that his non-apneic, if I could keep Bill on the side, his apnea is just 9.1. So we had a gentleman here that had a history of some hypertensive, high cholesterol, coronary artery disease, has a stent placed in, but yet no one had sent him off to get a sleep study done. And looking at his oral characteristics of his D5, here's a red flag. And after getting him tested and really learning the fact that he had severe sleep apnea, much worse on his back, warranted that we treat him. In his case, he wanted to go oral appliance. We put him in a SUART at the time, and we did a follow-up study with his SUART appliance in his mouth. And what you'll find out is that with his appliance, his supine AHF 61.5 improved to 3.4, and his overall apnea-hypopnea index from 32.9 went down to 2.3.
Wow.
So just opening up Bill's bite, I did not even do much AP, bringing his jaw forward, changed his breathing pattern, gave him enough room to possibly bring the tongue forward, open up the airway, but more importantly, affect his scores. Happy camper. But if you look at Tammy, our next case, Tammy comes in from the TMJ aspect, complaining of face pain, fatigue, and number one chief complaint to us is fatigue, followed by headaches, and the list goes on. What is interesting with Tammy is she was already being treated with a CPAP, and she was wearing a CPAP. Yet on the Epworth sleepiness scale, she scored a 9. So borderline. She was not getting refreshed sleep. She was not waking up like she wanted to. She was still fatigued. But yet, this is based on the fact that she wore a CPAP. So we requested in her case a sleep study, just to get a sense of where she was. And if you look at the sleep study, you'll find that her blood oxygen level went to a low of 84% during that study, as well as her respiratory disturbance index went up to 41.2. So anything greater than 30 would automatically classify as a severe. Here we had a severe young girl with an oxygen level that was down in the 84s. Her chief complaint being fatigue, even after being treated with CPAP. So with her, we opted to go oral appliance, but she also had an active jaw problem. So we started off with a temporary sleep apnea appliance. So we kind of modified it a tad. And what you'll find here is that her follow-up study, she had an RDI of 0.8, whereas the baseline was 41.2. And if you look at a minimum oxygen level of 84, her minimum with the device in the mouth went all the way up to 95. So you can only imagine what that did for her. At her first follow-up, no headache. She's sleeping better, not snoring, and her on board, the lower right portion, the sleep apnea is much better. And what we've got here is a little video of her journey, just to give you an idea of what it took for her to get where she got at.
Started having migraines almost on a daily basis, tight muscles in my neck, pain in my neck that would go all the way down my back. I'd have to sit on a heating pad every night just to be able to function the next day. That's when I started seeing a massage therapist, which helped but didn't take away the pain. 3 months later, I was diagnosed with sleep apnea, which helped some of the migraines for a short period of time. 6 months later, they started coming back, had gone back to the neurologist. He tried to give me a pill. He did give me a pill, which didn't really help. I had been to an endocrinologist, a regular doctor, homeopathic doctors, none of which could figure out exactly what was wrong with me. And
I apologize. Was there no sound coming through, doctor?
No, ma'am, there was no audio. You going to play that again?
Yeah, let me back that up. Sorry about that. Let's see if this sounds better.
having migraines almost on a daily basis, tight muscles in my neck, pain in my neck that would go all the way down my back. I'd have to sit on a heating pad every night just to be able to function the next day. That's when I started seeing a massage therapist, which helped but didn't take away the pain. 3 months later, I was diagnosed with sleep apnea, which helped some of the migraines for a short period of time. 6 months later, they started coming back, had gone back to the neurologist. He tried to give me a pill. He gave me a pill, which didn't really help. I had been to an endocrinologist, a regular doctor, homeopathic doctors, none of which could figure out exactly what was wrong with me. And about 6 months after I started with a CPAP machine, it stopped working for me. It would leak, and I just didn't feel good in the morning, and I never thought it could be a jaw issue. With all the pain, I could hardly function. I couldn't play outside with my kids. I was ready for bed by 7 p.m. at night because the pain would just wear me out. But I also had the sleep apnea that I was dealing with, which also causes you to be tired. If I didn't take a nap during the day, I could hardly function to get my kids in bed at night, cook dinner, and get up and function the next day. So I finally called the Center for TMJ Therapy, came in, they did assessments, and found out I was a 10 on severity because I had everything. And it also turned out that the jaw position was causing both the TMJ and the sleep apnea. I had no idea that the two could be so interrelated. And then looking back over the last 3 years, I've had migraines, headaches, facial pain, severe neck pain. I've had to have a massage therapist twice a month. I've had to see a chiropractor for the last year because of all the pain, and had no idea that the jaw could cause all of that pain. After a month after having the mouthpiece, most of the pain is almost completely gone. My energy levels are coming back. I sleep great because I sleep with a dental appliance at night. And I mean, life is becoming life again instead of being trapped by the pain. So it's just been such a huge difference in my life. But I would never have thought that jaw position could cause all of those symptoms.
So when we move on, what it basically boils down to is tomorrow you can change lives, one patient at a time. And I think it's important that we take this active role because we are actually positioned in a very good, unique position to not only identify facial pain, for that matter, or headaches, but also the sleep aspect, which is one that gets missed extensively. So what it comes down to is your next step. I would say start by screening all your patients. It's extremely important. Follow up with systems. Have something in place that's efficient enough for you to have a process. The system we have used and we continue to use, not to pitch this from a promotional standpoint, but we love Dental Writer. We have Dental Writer, and it's our workhorse. I say get trained, get educated, whether it's your deficiency is in facial pain, if it's your deficiency is in sleep, dental medicine, there's education out there. Get trained, get involved, and we ultimately use Dental Writer every day. And I've got a short video, once again, I'm trying to be a Hollywood star here, showing you our typical day. And this is how we use Dental Writer every single day. And with that, I want to thank everybody's attention.
Wow, that was incredible.
Yeah, we
Very
need a
nice,
standing
Dr.
ovation
Patel.
for that.
You know, right? I folks, I'll tell you what, so much with it.
I'll tell you, that was a great webinar, and I especially enjoyed the last part with the demo writer for music. You were certainly the conductor during the art of the exam.
I know, right?
Yeah,
A little bit in all fairness to everybody, even though I was asked to speak for Delaware, I really appreciate the opportunity, but at the end of the day, it comes down to deciding systems, and the system that really works in our practice has been Delaware ever since. I think it's been now probably coming on to 10, 11 years since we've had it, from the early days of Delaware to where we are today, and, it is what it is.
Yeah. Well, thank you so much. So join us, please, in Atlanta with Nierman Practice Management and Dr. Patel on May 9th and 10th. We'd love to see you there. It's at the Georgia Tech Hotel. Courtney, do you have any questions in the chat box?
Yeah, at this time, I don't have any pending questions in the chat box, but right now, for everybody on the line, I'm going to go ahead and unmute your line. If you'd like to jump on the line and ask Dr. Patel a question or share an experience, we'd love to hear from everybody. If you're not comfortable jumping on the conference line, no problem. Feel free to use the chat box in the lower right-hand corner. Just type your question in, and we'll make sure we get that moderated over to Dr. Patel. So if you don't want to be unmuted, please feel free to mute yourself, but I'm going to go ahead and unmute your lines now.
Dr. Patel.
Yes, sir.
Okay, I'd like to know a little bit more about the treatments you render for headaches other than making an OSA appliance.
Yeah. I mean, a lot of that will be based on diagnosis, but we provide injections if we need to. We definitely work with
trigger point injections.
We'll do blocks, whether it be occipital nerve block, trigger point injections, things of that sort. And in some instances, prescription management, from the standpoint of anti-inflammatories to muscle relaxants, to not that often, but if we have to put them on anxiety medications, we typically get the PCPs to take over care, but we'll monitor it. So in some instances, I found myself being a quarterback, really identifying what the root cause may potentially be, and then based on who should do what, reroute the individual and just keep an eye on them.
For myofacial cerebrogenic headaches, what sort of treatment do you render for that in general?
Those patients, a lot of them will be going to a physical therapist up the street that does dry needling. I do favor dry needling. I find it gives you good outcomes. But also looking at whether a postural component is playing a role, or in many of these cases, it's just the act of parafunction. Them firing up those temporalis does have a direct correlation with the upper neck. And if I can control parafunction, it's surprising how many of my neck patients don't have that issue anymore. So once again, I think the topic is the discussion should be more towards clinical pearls as far as what we do in our practice with this whole aspect, but specifically diagnosing. If you want to contact me directly, I'll be more than happy to have a lengthy discussion with you.
Okay, thank you very much.
You're welcome.
All right, great. Thank you, Dr. Feigenbaum. Great questions. Anybody else on the line have any questions they'd like to ask Dr. Patel or experiences in their practice that they can share with us? Okay, great. I hear silence on the line and no activity in the chat box, so I think you did a great job covering it, Dr. Patel.
Yes, thank you so much.
I think I left everybody speechless. They're like, oh my God. No.
Absolutely, I am. No, really, it was a great presentation.
Well, today's April Fool's Day, and aka All Fool's Day.
As some people may have already found out, right?
That's right. And we hope to see you next week. Our special guest next week is Dr. Steve Kirstensen, and he will be talking about pediatric airway concerns. So we'll look forward to seeing you at 7:30 next Tuesday, 7:30 p.m. Eastern Time.
Great. Thanks, everybody, so much for joining this evening. And again, thank you so much, Dr. Patel, for taking the time to come and educate us.
No problem. Well, thank you, guys. Take care.
Thank you.
All right. Good night, everybody.
Good night, everyone.